we have been talking today. We would be continuing that, but not about COVID proper. But we'll talk about a complication that has affected many in COVID. We have with us Dr. Nidhi, who's going to be discussing about POTS, Postural Orthostatic Tachycardia syndrome, which is one of the most common complications that we see. I mean, I wouldn't say most common, but yes, it is fairly common. Of course, Dr. Nidhi will be discussing this in detail. So, Dr. Nidhi needs no introduction, but just to start off our meeting, let me, for the uninitiated, let me introduce Dr. Nidhi Dhawan. She's the Secretary of the IMA and NDB and the Associate Medical Director of ENT and the Head of the Safety Committee in Shroff Charity Eye Hospital, Daryaganj. She'll be discussing about POTS today. So without much ado, I would request Dr. Nidhi to come. Over to you, Dr. Nidhi.
Thank you so much, Dr. Meenakshi. Why I was inspired to do this was because a patient was referred to me who has been through 7 or 8 doctors, and she was investigated very heavily. Everything else came out normal, and she was told that it's all in her head. And when I heard her history, seen this before, and it is very unfortunate that people who are suffering from POTS, Postural Orthostatic Tachycardia syndrome, get underdiagnosed. They get no diagnosis most of the times, and sometimes they get told that it is just in their head. So I'd like to reassure those people that it's not in their head, and I'd like to dedicate this talk to this lady who is a very strong lady and has been suffering since at least February that I know of. Could we have all mics muted at the moment? Thank you so much. So a very, very brief overview of what has been happening in the last week, though these figures now don't have much meaning. If we look from February, UK around 645 cases per million, US 260, India 16. We come a month later to March, India has fallen to 2.3, which most people estimate is underreporting. But my take on this is, even if it is underreporting, so long as people are not getting sick, so long as people are not reaching hospitals, and if it is just flying under the radar and not causing overwhelm of medical systems or of the population, because it is a virus which was new 2 years ago. Our body has been immune educated, and it is going to become endemic, and there are ways in which it will happen. Now, what I want you to observe in this graph is how Israel is, despite quadruple vaccination, showing this peak, which is way above the peaks of US, UK, South Africa, and India. And this is something that has been piquing my curiosity over the last week as to why that is happening. If we look at the fully vaccinated, over vaccinated countries, the countries with zero COVID policies, in January, at the peak of our Omicron wave, Singapore was kind of equal to India. Singapore had a zero COVID policy. South Korea was a zero COVID policy, reaching about 82 cases. March 18th, Singapore had risen to 2,000, New Zealand to 3,500. South Korea had risen to 8,000 cases. May 20th, all the numbers are coming down. India has been consistently coming down and hovering around now less than 2 per million. And you can take it with whatever pinch of salt you want. Weekly new hospital admissions is a better measure, and we don't have these figures for India. Singapore less than 100, UK less than 100, US less than 100, South Korea less than 100. With those numbers per million, less than 100 admissions, even the ICU admissions are not. So if you look at per million, 6.8 in US, 4.6 in Australia, 2.7 in UK. If you look at deaths per million, and even a single death attributable to COVID is one too many, but you're looking at these figures, which are like 2.6, 2.3, 1.4, and 0.02. For those who say that we have the WHO study, which says this is gross underreporting, WHO has used some statistical models, assuming that they will not get data from India. And there is a very, very incisive video by Print Shekhar Gupta, which has blasted that premise out of the roof. I suggest all of you and watch that analysis. Very, very good analysis. I'm not going to go very much into the detail of what is happening to other countries, but in India, we are consistently seeing numbers coming down, and we are consistently kind of staying close to the baseline. The Maharashtra figures, again, staying close to the baseline. Delhi, close to the baseline. We've seen the peak, it has come down. Kerala, definitely, even the 7-day average and new cases, these are staying close to the baseline. Uttar Pradesh, close to the baseline. What is interesting and stirring my mental muscle, we know that Indian demography is very young. And it's quite similar to South African demography. And that's what we thought, that, demographically, the only difference between South Africa and India was that India was better vaccinated than South Africa. But if we look at Israel age structure, it's not very different from age structure in India. It's kind of similar if you look at these two graphs. The aging population is lesser in India than in Israel, but the less than 65 is kind of very, very similarly distributed. And the very young, the less than 15, also very similarly distributed. Whereas in the US and the UK, you find that you could actually superimpose the two, and it's very similar. US and UK demography is very. Logically, then we should be seeing what is happening in India kind of mirrored in Israel, or the other way around, and what is happening in US mirrored in UK, or the other way around. We see that mirroring is happening in the US and UK, but we don't see that mirroring really happening between Israel and India. This is something that I would like to go a little deeper into, maybe at a later time, and figure out what's happened there. If we look at the daily new cases per million, Israel is 225, India is 1.5. If you look at the deaths as of, and this is cumulative deaths, You look at India, you look at the ivermectin belt, it's I don't really have to go too much into this. So the FLCCC is still sticking with their earlier recommendations. They're supporting it with data, and I would tend to agree with them. If we look at what is happening now, this is something that Sir had predicted is going to happen. Virus, and we were dealing with the acute illness, immune, hypercoagulable, prothrombotic, inflammatory state of the disease. But he said that once we are through with the acute phase, we will see long-term effects, which included thrombotic complications, autoimmune complications, and he even predicted that probably malignancies in the coming days. But if we see what has been happening in our OPDs also, hair loss I have seen, chronic kidney disease I have seen, thrombotic complications I have seen, palpitations and chest pain I have seen, cognitive disturbance and headaches I have seen, anxiety, sleep disturbance, post-traumatic stress I have seen, persistent cough, dyspnea I have seen, persistent oxygen requirement I have seen, fatigue, decline in quality of life, muscular weakness and joint pains I have seen. I have seen all of these. And I am an ENT surgeon. It is, when people come to me now, in the history taking, there are two questions that I add for everyone. One is, what is your immunization status? And the other is, did you have COVID? Because in line of these two questions, we need to figure out whether we need to add any of the lifestyle or pharmacologic measures which bring the immune system and the inflammation back to a more or less relaxed recovery stage. This is a post-COVID care clinic that has come up in the US. They have several branches, but what was interesting was that they have figured out that these are the things that they see in most of the people who have autonomic dysfunction after COVID. Their estimate is that it's 50 to 60% of people who land up with long haul COVID who will have autonomic dysfunction. And they have offered what they call EPIC, Enhanced Performance in Cognition Protocol, which is a series of physical and cognitive exercises combined with periods of rest. What I call this is pacing. So you would alternate between mild to moderate, well-tolerated, aerobic exercise with periods of mindful rest and recovery. And this is what is going to allow the body to keep increasing the tolerance to higher levels. Now, something as simple as breathing has both the sympathetic and the parasympathetic components. When we are generally in balance, you will see that our inhale and exhale are roughly balanced and equal. If we breathe in deep, we are actually activating the sympathetic system, and a prolonged exhale activates the parasympathetic system. So when we want to be cognitively sharper, when we want to be alert, we would promote deeper inhales and normal exhales. When we want to go into a meditative parasympathetic relaxation response, we would do a normal inhale and an extended exhale. Now, it's so interesting that we talk about the 3-4-5 breath in which, or 3-4-6 breath in which you hold your inhale for a count of 3, then you hold the breath for a count of 4, and then you exhale for a count of 6. If you are not able to sleep and you do this, you will, I promise you, sleep within the next 10 minutes of this breathing. This is how powerful it is to activate the parasympathetic system. Now, what really is happening in POTS is that there is a postural volume shift, which means that the blood is kind of shifting to the lower extremities. And there is a relative dehydration or hypovolemia. So because these people are already in a sympathetic hyperdrive, because the autonomic dysfunction to also work towards tachycardia, the vascular receptors that block the vasoconstriction causes pooling of blood in the periphery. So there is reflex tachycardia also. In the gut also we find that there is vasodilation. All in all, what it moves to is a tachycardia on standing up. So seem to be both an exercise intolerance and relative hypovolemia, and all these symptoms can be tackled by, at least initiated by, non-pharmacologic measures, things that people can start doing at home from day one. There are some very simple physical maneuvers that counter the venous pooling in the lower limbs. So, that stress ball that people just squish between their fist. So if you're squishing up a rubber ball, you are activating the muscles of the upper limb, which reflexly tells the brain that there is movement without causing hypovolemic pooling. When you stand up, you can cross your legs or just simply tense your muscles when you're sitting. If you just dig your heels into the floor, you will find that your entire lower limb is activated. So pace your physical activity. You can to the level that you can. Don't overexert. If you feel that you are feeling dizzy, lightheaded, or there is any weird sensation in the head, sit down. Restart from the start. Include periods of rest, and we'll come a little later to what rest really is, because typically POTS affects young females from say 16, 17 to 35, 45. Typically, it affects people who have been used to a fast-paced life, type A personalities, driven, the routine stuff, and it's like it's, an alien is taken over their body. So we'll come to what rest for these people can mean. You have to reframe the concept of rest. Hydrate well and include salt, because there is relative hypovolemia. Eat smaller meals, maintain a comfortable ambient temperature. Something as simple as humming and singing can improve the vagal tone. If you're finding that, standing up is causing you to feel dizzy, you can start elevating the head end of the bed. And in the resting stage, that might help to condition the body, because it has already been deconditioned. Compression stockings is an extreme measure, but there are people who are unable to get out of bed also with this, and it would help. Sometimes we are suppressing the cough, but forceful coughing actually might be a reflex to maintain the brain circulation temporarily. So there are predictors. In acute COVID, we know that the demography, if you are an elderly male, you are more likely to have severe. Young males or young females, it's just that they are more likely. Medical comorbidities have a definite association with more severe disease and poorer outcomes. The viral load or initial severity does predict how bad the acute phase will be. But what is important is that vaccination has so far shown to be protective against severe disease, if not against infection. So it is not sterilizing immunity that vaccination provides, but it does provide protection against severe disease. What is important is that Omicron and its evolving variants have been like a beacon of light in that otherwise stormy sea. They are like the live attenuated vaccine that is quite effective. It is running through the populations. It is not causing that much hospitalization or ICU admission. It is running out of steam in 10 to 12 days. But because it is still SARS-CoV-2, it has increasing potential for long COVID. And there are several theories which have been proposed. Those could be that there is an autoreactive immune response. Definitely there is microclotting and microvascular dysfunction. It can cause gut dysbiosis. It could lead to reactivation of other viral infections which are otherwise hidden. It does cause systemic and tissue-specific inflammation, definitely in the heart and the kidney and in the brain. It could also be that there is viral antigen persistence, which is kind of keeping the immune system triggered. These are all areas of research which are currently being explored. Whatever is happening at a cellular level or a molecular level, histamine seems to be playing a big role in it. And histamine classically works on H1, H2, H3, all three receptors. If you remember, sir used to tell us कि एक cetirizine और एक famocid सबको add कर लिया करो, which was H1 and H2. There are studies which say that famotidine 40 mg given at bedtime along with cetirizine given at bedtime improves outcomes in acute COVID also. The disease spells, the feeling of lightheadedness is because the disturbance of the sleep-wake cycle also. It could be because of the central actions of histamine at the H3 receptors. So histamine has a huge role to play. The gut, gastric acid secretion, increasing heart rate, H2 receptors caused all of this. And we know that cimetidine, ranitidine, famotidine, and nizatidine help in that. The initial response from H1 receptors is vasodilation, bronchoconstriction, causing pooling and causing cough, platelet aggregation, and hyper thick mucus secretion, again causing cough and predisposing to thrombotic complications. H1 receptors can also cause various downhill cascades. So if and whatever works for you, I mean, you could use the traditional chlorpheniramine or promethazine also, but fexofenadine, cetirizine, all these help in the immediate effects of H1 receptors. What gets missed in routine treatment of long haul COVID or of POTS is the H3. And sometimes adding beta histine, spin-free, Vertin, and disclosure, I don't have any financial gains from any of these products, but I know that adding these improves immediate response as well as improves long-term outcomes. So among the antihistaminic, for loratadine, but I'm not very finicky. You could do anything. So loratadine, famotidine, and beta histine at night can significantly improve outcomes. So what is POTS is a dysautonomia in which there is an inappropriate increase in the heart rate on the change of posture. Now, generally speaking, there are very strict guidelines that it should be 30 beats, it should happen in 10 to 15 minutes from getting up. But those are all observations and statistical reports. There are people who will not notice those kind of increase and yet have all symptoms, and those who will have lesser increase and yet have all symptoms. So it is a clinical diagnosis which is supported by certain criteria. It usually affects the younger age group. Usually there is a distinct female predominance, and because it is in this demographic profile, it often gets dismissed as being inside your head. It is not. The prevalence of even non-viral, non-COVID POTS in the Western countries is to the tune of 1% in the population. But typically, POTS can be precipitated by an immunological stress or even a physical and psychological stress. So viral infections, vaccinations, trauma, pregnancy, surgery, and some psychological stresses can precipitate POTS. Current treatment strategies have been to bring down the heart rate. Ivabradine and beta blockers like Indral have been used. Compression stockings to improve return to the heart. Some other possible treatments when the first line are not working are midodrine for low blood pressure and those foggy moments for cerebral hypoperfusion. Pyridostigmine if the beta blocker ivabradine first line are not working. For combination works better. Modafinil for brain fog. Modafinil is one of the anti-Alzheimer treatments. If there is more complaint of brain fog, then that has been added. Now, all these are not my first line treatment. These are the things that are available for traditional POTS treatments. The role of anti-mast cell drugs, I told you that among the anti-H1 drugs, I prefer loratadine because loratadine has some anti-mast cell action. We know that there is inappropriate stimulation of mast cells and that causes the MCAS. If loratadine alone is not working enough, then we can also add sodium chromoglycolate, or what we used to call chromal. It used to come as eye drops and even as a nasal spray. Rehabilitation must involve pacing and really prolonged treatment, because if you're looking at activated mast cells, you're looking at 3 to 4 months of a life cycle, and the inappropriately activated mast cells can last up to 4 to 6 months. Their progeny hence will also be inappropriately activated. So we need to run through 2 or 3 cycles of long-term loratadine or sodium chromoglycolate kind of picture. We also know that, on a molecular level, what is the inflammasome and the nuclear factor kappa beta pathways, which means that giving ivermectin once a week or twice a week will also help, along with vitamin D. So if you are looking at what we call a female predominant persistent immune dysregulation of the post-COVID syndrome, then we are looking at 6 types of symptom complexes: fatigue, dyspnea, myalgia, orthostasis, headache, and chest pain. These are the 6 phenotypes that we generally see. The interesting thing is that it's been found to be raised in 61% of the patients. The fatigue predominance is seen in women, whereas the dyspnea predominance is seen in men. CRP and ESR, CRP, which is otherwise the surrogate for IL-6, but CRP and ESR are elevated only in 17 and 20% respectively, whereas IL-6, even without causing CRP rise, is elevated in 61% of the patients. So if you look at the central axis, then they call it the central sensitization phenotype, which means that fatigue, myalgia, and orthostasis is more common in females and is similar to the chronic fatigue syndrome or the CFS. Among this, the fatigue seems to be the highest driven. So what is happening here is a part of the cytokine release syndrome, or the CRS. IL-6 seems to be the major player in post-acute sequela. It is an innate hyperresponse. It could be largely IL-6 driven. And it is also associated with monocyte chemoattractant factor, which means that the monocytes also get activated. Associated with adverse outcomes, that means prolonged disease. It inhibits antiviral activity, so it predisposes to more severe acute disease. And if you remember, the tocilizumab, which is a selective IL-6 blocker, was protective in both acute and post-acute sequela. Now, interestingly, men have a higher IL-8 and women have a higher IL-6. And a higher IL-6 has a higher correlation with disease progression. So at a molecular level, perhaps this is the reason why women have a lesser acute phase and higher chronicity. The women, in any case, in their post-pubertal, premenopausal age, have higher, we go into it, high ESR, which cycles through their cycles. So IL-6, TNF alpha, and IL-1 beta otherwise are also higher than male averages. As we said, IL-6 can otherwise be blocked with tocilizumab, sarilumab, or cetuximab. These monoclonal antibodies require hospital admission, and they require parenteral administration. Effects of IL-1 beta can be blocked with anakinra or canakinumab, but there are easier ways to quiet the fires raging in the body. What we find is that it's setting up a vicious cycle. So the CD8 that produces interferon gamma causes direct tissue damage. The direct tissue damage releases the molecular patterns of tissue damage. The DAMPs take this reason IL-6, IL-1, and TNF alpha. The CD4 cells in the presence of IL-6 and TGF beta transform to the Th17 response, which secretes more IL-17, which also activates the immune cells. So it's like a vicious cycle which is perpetuating itself. If you remember, we had discussed IL-6 earlier. We know that IL-6 is secreted by a whole lot of cells: monocytes, macrophages, endothelium, B cells, T cells. Interestingly, hepatocytes, liver cells, keratinocytes, skin cells, adipose cells or the fat cells, and fibroblasts. So if it is secreted by all these, its effect also is present on a wide array of cells with IL-6 receptors. It works on T cells, B cells. Importantly, it works on vascular endothelium. It works on monocytes, and it works on hepatocytes. The vascular endothelium, monocyte, and hepatocyte seem to be the key features for IL-6 being the mediator for POTS. There are diverse functional downstream effects, among them being increased CRP from liver and decreased albumin production. Albumin is a countermeasure to fibrinogen, and it's an anti-inflammatory protein that we produce. Humans with defective or deficient IL-6 receptor tend to manifest a hyper IgE syndrome. So they have, so I actually IL-6 is a molecule which is playing the nuanced dance between inflammation and counter-inflammation. So people who are deficient in IL-6 have recurrent staphylococcal or mycotic skin infections. They have recurrent allergic skin problems. So there is this complete axis of post-COVID syndromes, which is fibromyalgia, chronic fatigue syndrome, and POTS. There is this central sensitization complex, which seems to affect women more. The common pathway seems to be immune dysregulation. IL-6 is elevated in all of these symptom complexes. Diagnosis is often elusive and frustrating because everything seems to be normal. You might find a little bit of monocytosis, you might find a little bit of CRP rise, you might find a little bit of platelet activation. You might find small clues everywhere, but it's largely normal. Imaging will be normal, MRI will be normal, and the patient is saying that I'm feeling dizzy. The CT scan will be normal. There is nothing to be found in the chest or in the brain. The symptoms are multiple. They can be related to the head or to the gut. The labs are normal. One thing that you might be able to get is, with people wearing smartwatches nowadays, you might be able to see the heart rate variability that is otherwise a normal thing, is kind of knocked out in these patients. So the sensitization of the brain and the spinal cord to stimuli is reduced. The reduced stimulus threshold for both perception and amplification of existing stimulus, which causes a hyperreaction in these patients. And there is a persistent sympathetic hyperactivity along with a persistent parasympathetic hypoactivity, which results in palpitations, exercise intolerance, difficulty in initiating and maintaining sleep, and sensitivity to external stimuli. So if you look at this, you will also notice that this is also the profile of people who have migraines. That they're hypersensitive, bright colors, bright lights, they feel overstimulated with noise. They need some time out. Melatonin will help in this. So as I said, there are definite diagnostic criteria. The POTS classically is described as a heart rate increase of more than 30 beats per minute within 10 minutes of standing up, or more than 40 beats per minute within 10 minutes of standing up for adolescents. This is a statistical test, and though cardiologists would say that this is a necessity, I feel like, for somebody whose resting heart rate is, say, 60, 62, an athlete, even 90 is tachycardia. And for somebody who runs around 80, 84, the tachycardia limit would start at 100, 110. So these are all statistical things, and we are not treating statistics, we are treating patients. We need to become patient focused. We need to become individualized in our approach to a person. So the orthostatic intolerance can have tachycardia, it can have hypotension, or it can have feeling of a blackout, or what we call the vasovagal syncope. The patient will feel slightly shaky, there might be sweating, pallor, palpitations, there might be, I'm looking for that word, what was that word again? And it's something that is happening to them more often now. These patients tend to sometimes get misdiagnosed as vertigo. This is not classical vertigo. And their vestibular testing will come normal. We could do this study, but I have a feeling that vestibular testing will come out normal. The common causes are central axis dysfunction, reactive hypoglycemia, mitochondrial disorders, mast cell disorders. We have dealt with detail in both of these. Autoimmune attack on antigens of the body. Epstein-Barr viral infections have also been shown to be associated with it. Lyme disease has also been shown to be associated with it. And comorbidities like anemia and diabetes are also predisposing factors. In the common symptoms, 99% of patients report lightheadedness. 97% of patients report palpitations. 94% of patients say that they feel like they could pass out. There is shortness of breath, muscle pain and abdominal pain in more than 80% of patients. So, किसी का माइक ऑन है डॉक्टर गुप्ता, डॉक्टर एनके गुप्ता, आपका माइक ऑन है, डॉक्टर एनके गुप्ता।
दीपांशु बच्चे सब सो रहे थे, हम उनके यहाँ जाए जिसके साथ जाना उनके यहाँ गए।
Ritu, could you please mute Dr. Gupta?
बोला मम्मी आंटी का फोन आना था, शायद काम चल जाए, मैं इनको भेज के
Dr. Gupta, could you please mute your mic, Dr. Gupta?
अभी कहाँ कुछ किया?
So the symptoms of dizziness, sweating, fatigue, shortness of breath, chest pain, which are common. You can see what is happening is that when you stand up, the blood is pooling to the lower body, leaving the shoulder, neck, and head area relatively ischemic. Increase your fluid intake, eat smaller meals, take fewer carbohydrates which pool the fluid to the gut. Avoid prolonged standing, increase salt intake. These are very simple measures to start off getting to a better state. This looks like a very involved and a very complicated chart, but if you just need to look at two factors in this, there is a hyperadrenergic, that means a hypersympathetic state, which is causing abnormal autonomic reflexes, exaggeration of sympathetic nervous system, and mast cell activation. At the same time, there is peripheral pooling, physical deconditioning, excessive vasorelaxation, or insufficient vasoconstriction. All these are contributing to classical symptoms of POTS. The exercise and non-pharmacological treatment goes a long way towards the rehabilitation of these patients. And on an average, a POTS patient sees 7 doctors before receiving a diagnosis. If we are seeing that a patient persistently tells us that I'm feeling lightheaded, I feel like I could be passing out, I have anxiety and I have palpitations, consider POTS. It's not rare. And we can start treating it with a little bit of empathy. 90% of patients being female, mostly being between the ages of 12 and 50, misdiagnosis is common. As I said, 75% of patients are told their symptoms are in their head. And about 50% of the patients develop POTS after an infection. Even COVID, the 50% of patients that we are seeing now could be post-COVID POTS. The various factors which are contributing to it are neuropathic, hypovolemic, primary sympathetic overdrive, immune related, and some of these patients could be paradoxically, really flexible. People who have either Ehlers-Danlos syndrome or even who have been doing yoga for a very long time. What we can do for these people is simply monitor their heart rate, do their sweat test, ask them to shift to deep breathing, check their heart rate variability, ask them if they start feeling like this 10 to 15 minutes after standing up, or within 10 minutes if they stand up suddenly. If they are continuing to have sleep disturbances, chest pain, or persistent, they're going to pass out, dizziness, dyspnea, or persistent cough again, consider POTS. I have no experience of this area of the circle, but I can tell you that this area of the circle really works with a lot of people, and I can tell you out of anecdotal evidence. जैसे सर कहते थे हम इसके ऊपर पेपर लिख सकते हैं, लेकिन अभी हमारा anecdotal experience है. If we do graded increase in exercise, if we avoid the triggers, अगर किसी को postural orthostatic tachycardia syndrome experience हो रहा है और वो कहता है कि मुझे एक फ्लाइट स्टेयर्स चढ़ने में अभी दिक्कत हो रही है, पहले मैं 4 चढ़ जाता था, तो it is better that they avoid stairs or take them slowly. Compression garments, increase salt intake, increase water intake will help to improve exercise tolerance. Sometimes we may need to give vasoconstrictors or sympatholytic drugs. Sometimes we need to give heart rate inhibitors like Inderal or ivabradine. Sometimes even blood volume expanders, but this is not something that needs to be done in the first line. So these patients will feel, will have any one of these areas which will, contribute to their clinical profile. The physical activities that should be encouraged and should be very gradually increased are gentle yoga, water aerobics, horizontal exercises like riding a bike, like walking, and walking very slowly. If you think, sit down wherever you are. Restart when you feel better. Take a vacation to areas which are cleaner, which are less crowded, and which have a slower pace of life. Concerts, so music seems to be the central theme that causes parasympathetic reset. Things that you like, gardening, driving. The emotional stress sometimes can precipitate POTS-like symptoms. So, for our loved ones who want to know that we are doing well, they need to talk to us, and a video call can be an overstimulation for such patients. So for the start, you can say, okay, let's, just to make sure you're doing okay, and then shift to audio mode. If you want to go to family events, stay only as much in the activity as is comfortable. Generally, cognitive effort can be, and cognitive output can be increased by just maybe reading a book, taking a new class, maybe teaching somebody something, writing your journal, listening to music, or trying to a new surrounding and experiencing newer things. So these are the small cognitive challenges that improve the cognitive function. It is important to note that submaximal exercise जिसमें हम out of breath नहीं होते, उसमें oxygen uptake जो है वो increase जरूर होता है, but this is aerobic increase. It is increased not by raising our breathing rate, which is largely staying normal, or in fact even coming down a little, but by increasing the depth of breathing. Then it comes to a point where the anaerobic threshold is reached, where increasing the tidal volume further is not possible, and it in fact comes down a little, but the rate of breathing increases sharply. So if we are working at either just this aerobic threshold or just a little above this aerobic threshold, that is the best pacing routine for these patients. This is what I was just explaining to you. And blood lactate rapidly increases at this threshold. So if you are doing low intensity, prolonged exercise, then the lactate kind of stays more stable. Moderate causes a steady rise in, steady but slow rise in the lactate levels. And high intensity exercise, which we say is good for mitochondrial health, by the way, will cause a sudden steep rise of lactate in the blood. We are in the rehabilitative zone focusing on this area, the area between low to moderate intensity. As we are able to increase the duration of exercise for these patients without feeling uncomfortable, we can focus then on the mitochondrial health and VO2 max. And this is again just, doing more on what we've just gone through, that low intensity is till you reach your aerobic threshold, moderate intensity is the transition phase, and high intensity is when you cross your aerobic threshold. For these patients, we do not want to cross the anaerobic threshold. The lactate in the steady state between low and moderate intensity is, maintaining a steady level. So if you are a recovering type A, if your pace of life has been very fast, if you are a hugely independent, probably woman, young, very driven, it is okay to treat yourself with the same respect and compassion that you give to the rest of the world. Rest is not taking too much time away from your daily work. It is also an activity. It is also a skill. Rest is not about the duration of what you don't do, what you would otherwise usually do. It is just about getting into a parasympathetic state, and that could be just 30 seconds of deep breathing, focusing more on the exhale than the inhale. So, those feeling of palpitations, headache, lightheadedness, take 30 seconds, recharge your battery, go into the relaxation state and restart again. Recovery is going to be a hard road. It is going to be a long journey. Sometimes you will feel like, you just can't do it, because no matter what the improvement, you thought that it's back to square one. But You have to keep trying because the road may be bumpy, but if you are headed in the right direction, you just have to keep on walking and you'll get there.
Brilliant deliberations along with very nice and simple messages in the end. So thank you so much, Dr. Nidhi, for working so hard on this very very important and common syndrome that we have had so many patients with. Not to use the word loosely, but this can be very debilitating. So when you have a headache, it is not measurable. When your blood sugar rises post COVID, that is also not measurable. But when you can feel your heart pounding out of your chest, and when you put on an oximeter and you see that your pulse rate is high, that in fact even elevates the
Makes it
problem
high.
even more.
Yeah.
So, this is, as I said, I don't want to use the word debilitating loosely, but it can actually cost our patient their mental peace as well. Often underdiagnosed. A lot of times we just say this is anxiety, and it is, something. The anxiety is what is causing your heart rate to increase. My own father had to deal with this, and first we had to treat him for this. So I know that this can actually, be a problem. We've had so many patients in our OPD who've struggled with POTS, and it does get better with time. But that the right diagnosis at the right time is the key. You've talked about parasympathetic state of mind. I think Sir has talked about it so often and so much. So he used to say that this he did a whole series just before he had to leave us. He did a whole series on Hanuman Chalisa, and he said that that Hanuman is equal to Pran Vayu, which is equal to you meditating and you doing these breathing exercises. And that's exactly like every single chopai he discussed in great detail, showing us the importance of parasympathetic state. So very reassuring to see that all of us gotten together here are almost on the same page, whether it's in the spiritual realm or whether it is in the medical realm. It's very very reassuring to see this. The floor is now open for questions. If anyone wishes to ask anything or discuss anything or share a story or an anecdote, we'd be happy to hear. Dr. Sanjeev Agarwal has asked a question: is there any significance of leg raising while lying to redistribute circulation?
So we don't want to decompensate the body further. I would not say do leg raising. What I would say is that जब जैसे हम in the relaxation response, we say कि अब आप शवासन में लेटे हो, अपने forehead पर focus करो, अपने upper limb पर focus करो, अपने abdomen पर focus करो. So we are actually relaxing the whole body. But in these patients, I would say that you actually should ask them to contract their lower limbs when they are lying down, so that you are conditioning in fact, even when we are sitting, when we are sitting, our feet are very loosely on the floor. And when you want to activate the lower limb vasculature, you should just dig your heels in, and you will find that you're in a semi standing position, and the body needs to recondition to active venous return. So we should not encourage raise your legs unless we are finding pedal edema. I also would like to, I'm seeing here, Shikha Mittal is the patient that I'm talking about. She really went through 7 or 8 doctors before she came to me. She was
the ninth one. You were the ninth one.
Okay, ninth one. So if we could just have Shikha share her story for a bit, I would be very grateful.
Yeah. I'll be happy. Should I share?
Yes, please go ahead.
Okay, on 3rd of Feb, I was lying down about to get, sleep, and I suddenly felt that my entire room is rotating, and I felt palpitation and my heartbeat was very fast, and I had never experienced something like that. And this entire experience went on for 3 hours. And I did a lot of prayers and whatever I could do. And then after that, I just slept for 2 hours. From 3rd Feb till now, multiple times I have felt, blackouts, and I felt that I'm going to faint, and my heart palpitates. I can feel my heart at a very high pace, and there is always a constant dizziness over here in this part. Sometimes it's very high, sometimes it's very low. My legs sometimes feel that I can't feel my legs too much sometimes. I get breathless very, very fast now. I live a very high paced life. I do yoga, but in yoga, my entire what do you call, I can't do that kind of yoga anymore. Like I'm forgetting the simple word that I wanted to say. I'm forgetting words a lot, and sometimes I feel brain fog, like baat karte karte I will lose my thoughts. And you know sometimes I feel that and in between that entire experience, the first month was the toughest month, which was February. I had almost 6-7 days of non-stop massive headache. That headache was so high that I had to pop pills 3-4 times a day to manage those. And in between, when I started experiencing this, I thought that my cervical is, impacting me because I have cervical slip disc. So the first call I did was to my cervical doctor in Bombay. From there, that didn't happen. Then I had to see another doctor. Then I had to see another doctor. Then I went to Bombay. I saw another doctor. In between, I did Kerala therapy. I did, now I've started acupuncture. But before that, I was taking another doctor's opinion. 2 homeopathics I've already tried. Anything to me, like it didn't give me any relief at all, in spite that I've taken 1 week of homeopathic. So Ayurvedic Dawai, I have tried Ayurveda from Delhi, one of the top Ayurvedic doctors, Dr. Sudha. Ayurvedic Dawai didn't do anything. Some days goes a little okay, some days goes little better than okay, but I'm not perfect any day. But most of the days since 3rd Feb till now, I have had massive anxiety. And by the way, I have never faced any anxiety or any palpitation. मुझे ऐसा कभी नहीं हुआ है. So panic attacks आते हैं मुझे कभी कभी कि I'll suddenly feel that I'm going to die. Suddenly I'll feel that. And one of the very interesting things that happened to me was even a small bit of negative news, like as small as somebody unknown to me died, I would start feeling panicked, and these palpitation will start, and I will feel dizzy more. My head will spin. So this is what's been happening. And last about 10 days back, for the first time, I had chronic cough, very chronic cough, like so much so that I don't even know how to express it. It is giving me like very, very unmanageable feeling कि इतना कॉफ आता है कि सडनली वो 10-15 मिनट तक कॉन्टिन्यूसली इतना ज्यादा होता है कि उसका पेस बढ़ता रहता है. Like this is the first time that has happened. So doctor has been treating me for chronic cough, and my running nose was happening again and again. So, and this has happened for in this chronic manner for the first time. But before that, multiple times, little cough. But this time, the chronic cough is at its epitome. So I have been getting treated by Dr. Nidhi. So I'm doing whatever ma'am is saying. But like ma'am just said that it's going to be a long journey. I don't know. I've already crossed 3.5 months, and it's impacted my entire life. I'm just a changed person. I feel I'm a patient now. And yeah, but I'm very, very positive person. I'm extremely positive and self-motivated person. I feel that because I'm self-motivated person in general and I'm such an extraordinary positive person is the reason why I could handle all of this alone. I also live alone. But since Nidhi ma'am has come, I'm doing like my positivity 100% has come back. Whatever I had lost in last 3.5 months of going through this, at least she's given me the diagnosis. At least she's given me the way forward, and I know that it might take another 2 months, 3 months, 4 months, but at least I know that I will recover. So thanks, ma'am, and that was just a quick story.
Thank you very much, Shikha. But you notice everything is, very, very typical, and everything is so easily dismissed by a lot of people who don't take the time to listen to the patient.
Yeah. My first neurological doctor didn't listen to me, by the way. He just didn't listen to me. I won't name, but I'm just saying.
No,
My
sir.
neurological doctor didn't even ask me what are my symptoms. All he wanted to see was my reports, my MRI reports. And he's like, "Tumhe kuch nahi hua hai, bas Vertin le lo and you'll be fine." Then I took Vertin for 10 days. Everything was increasing. Nothing was getting decreased. Everything was increasing. So yeah, he's one of the top neurologists in Delhi, by the way.
So what happens with these complicated and interwoven chemical processes is that, typically in this group of doctors, you will find that we are people who will, typically give 2 or 3 or maximum 4 drugs. We are not very, ye bhi le lo, wo bhi le lo, wo bhi le lo. We are all very focused on the minimum for the maximum. But, these patients like Shikha would require, say, an H1, H2, H3, तो ये तो 3 दवाइयां हो गई. They would require vitamins B, C, D, तो 3 और हो गई. अगर CRP raised है, तो they will require cycling with colchicine, तो ये 1 और हो गई. अगर heart rate high है, तो they require Inderal or Ivabradine, तो 1 और हो गई. And when you're writing that down also, it causes doctors like us a lot of anxiety. But as Dr. Sanjeev has pointed out in the chat, Shikha, you will recover. It will be a slow and long journey. It will require you to slow down. As you said, you have been a very fast-paced person. So it will require you to slow down. And it is... it's very illuminating. She's that typical person that, she talked to me, I think 3 days or 4 days ago, right? It's not been more than a week.
No, Sunday. We talked on Sunday. Last
so
Sunday.
1 week. So yeah, 1 week. And the minute she talked to me, I told her that, Shikha, this is not anxiety, this is POTS. And we need to be mindful of Harek se. I think, Meenakshi, you would be doing that. It has become a reflex. Have you had COVID? Have you had your vaccination? Because there are so many things that we need to now start dealing with as it is becoming endemic and as its long-term effects are showing up.
Funny that you mentioned that, because my first question to her would have been, when did you have COVID, not if you had COVID.
I was never detected with COVID.
So she never tested positive, but she had features.
Okay.
And my RT-PCR has always been negative.
What medicine was given to you?
For what, ma'am?
For all this POTS.
Ma'am, wo sab...
Nidhi ma'am is giving me medicine. But before that, I was never given
a diagnosis, Dr. Kiran.
Huh?
She was not even given a diagnosis.
No, I just want to know which medicine Dr. Nidhi is giving her.
Yeah, that prescription doctor.
But we'll share it not on YouTube Live, but we'll share it, Dr. Kiran. What I'm giving her, we'll share it.
Okay. Thanks.
So this is not for medical advice. This is just to make people aware that things like this happen and they are treatable.
If I may, Dr. Nidhi, CRP, did you make a note of it?
So CRP is 0.9 and the lab value is 0.3. So we have started her on colchicine.
0.9 milligram per
A
deciliter.
deciliter. So we have started her on colchicine also. But मैं वही कह रही हूँ ना कि आप एक चीज देखते हो फिर, and CRP is the surrogate for IL-6. But interestingly, all these papers report that IL-6 may be elevated even without CRP.
Okay.
And I just want to tell all the doctors on behalf of just being a civilian, that listening to patients is something, the most important part for doctors. And if doctors will do so, people will not face what I have faced. And I have faced the darkest time of my life. I have gone through darker times in my life, but honestly, this feels the darkest because every day I felt I'm dying. I could fight domestic violence, sexual harassment, but I'm unable to fight POTS. That's how serious this is.
Madam, what is the recovering type A personality?
Sorry?
What is the recovering type A personality?
What is the
recovering type A personality?
Recovering type A personality is that you have to slow down. You have to recover from being type A.
But
And
that is, yes, I agree. But that type A personality, you cannot get. It's very difficult to get them out of it.
is.
Because, the moment you put them into that parasympathetic state, they are just, if you say 30 seconds, 29th second, they are just thinking ki 30th second ka khatam hona hai, get back to my work. So that is, it's very difficult for them to do that. But yes, slowing down. And so what sir used to say about getting into the parasympathetic state, he used to say, kuch bhi ek mantra dhoond lo and usi ko bolte jao. So whether it is Hanuman Chalisa, whether it is Ekonkar, whether it is, just ABCD. So ye bahut frequently wo bolte the ki ABCD, EFG, HI, JK, L, M, N, O, P, ye hi bol lo. And just keep saying it and then say it in a tune and you will reach the parasympathetic state. Anything, and because repetition is, by definition, it is calming. So, that is something that sir used to say very frequently as well about putting us in the parasympathetic state.
Is the Inderal going to help such people? Inderal? 20 milligram, 30 milligram.
Yes, it will. It will. When the heart rate is what is causing the problems, Inderal does help. But
does help.
No, it does help, and so does ivabradine. What we need to do is figure out whether so all of these also cause already we are dealing with orthostasis.
Also, I had, not now, of course, but a year ago, I had read several studies in which they were saying that ivabradine should be preferred over beta blockers in POTS because, all these beta blockers, as you said, they cause hypotension, which also adds to the fatigue, which is also a very common problem in COVID. So in COVID, so I since then, I have never given beta blockers to people having POTS because this it does actually
doesn't cause hypertension.
What? No. Ivabradine doesn't.
Ivabradine is not, it is not a beta blocker. So this does not cause hypertension. And as I said, my father was dealing with it. He was dealing with it in the first not the first wave, but first wave. So I looked into this quite closely, and yes, beta blockers. So ivabradine was given preference in a lot of studies. I don't know if you sort of made the same observation.
Yes.
But so I think that's all. A lot of positive messages for you, Shikha. I hope that your recovery, albeit slow, it is steady.
Thank you. I'm under Dr. Nidhi now, so I'm very, very positive.
Yes, so that's a great. I'm quite happy that you found. I think on this note, we may end the session today. Thank you everyone for joining in. Thank you, Shikha, for coming in and sharing your story with all of us. And a big thank you to Dr. Nidhi for enabling this and doing this really elaborate discussion on POTS. It's one of the main it's one of the first things that I started working on very closely when it came to COVID. So it's a pleasure hearing your views on this, Dr. Nidhi, today. And thank you again, all of you, for joining in.